In part 4, we're going to talk about a number of generalized conditions which predispose to oral cancer. These will vary from conditions that you will see relatively frequently through to others which are very infrequent indeed. We introduced the concepts in the last section about potentially malignant oral disorders and focused largely upon the lesions, leukoplakia and erythroplakia. But now we really want to discuss a number of generalized conditions which have other signs and symptoms in the whole body and which confer an increased risk of the development of oral cancer. The main list of these is, as you can see, on the right-hand side, and we'll talk particularly about the top 4 of these. Some of them will be mentioned in a bit more detail in some of the other sections of the course, for example, in the fungal infections and also in immunologically mediated disorders of the oral mucosa. Others such as lupus erythematosus, syphilis, Keratosis congenita and so on are incredibly rare. You're very unlikely to see them, but they also do confer an increased risk of the development of oral cancer. Chronic hyperplastic candidosis has been mentioned previously in the fungal infections section of the course. As you can see from the clinical pictures here, the classic presentation of that, of a mixed white and red patch, which is present at the commissure of the mouth. These can vary from fairly uniform white plaque-like lesions through to very worrying red and white patches. We do also see lesions of chronic hyperplastic candidosis on the lateral border of the tongue, which, as you can imagine, given that is an area of high risk of development of oral cancer, these lesions can sometimes be concerning. So here again is the classic presentation at the commissure. The first part of the buccal mucosa in from the commissure of the lip is a relatively well defined but a little irregular mixed white and red patch. These all need biopsied, and the biopsy pathology again is presented in some of the other sections of the course, but just in summary, the surface here is keratinized, which gives it the white appearance clinically. Within that keratinized surface, there are a number of fungal hyphae, which we identify using a PAS stain. The epithelium itself is hyperplastic. You can see long rooty pegs extending into the lamina propria, and the lamina propria itself contains a fairly dense inflammatory infiltrate, which is dominated by lymphocytes and plasma cells. Also of note, within the keratinized surface layer are a number of neutrophils, which are drawn there by a chemotactic gradient in order that they might deal with the candida hyphae directly. The second of these conditions is actinic keratosis, and this is due to the damage which is caused to both skin and lips due to exposure for UV irradiation. On the lip, they tend to be on the lower lip, that is a little more everted usually and is more prominent, so it tends to get a higher exposure of UV irradiation. And the clinical appearance of these lesions is largely as you see here. The lips tend to become rather red and atrophic looking, sometimes with crusted areas on them, and very often there is a change across the whole of the lip, but with particular focal areas that look a little bit worse. And these again do have a significant pre-malignant potential. The patient who's presented here disappeared to clinical follow-up and then presented at some point later with their carcinoma. The clinical outcome for carcinoma of the lip, because they tend to be identified and diagnosed at an early stage, is good. Nonetheless, these present significant treatment problems, particularly in relation to reconstructing a lip and so on. Oral submucous fibrosis is a condition that you may see in the UK depending on where you work and your patient population. It is a condition which is predominantly seen in patients in South and Southeast Asia and in their populations, their communities around the world. It is associated with PAN, which we introduced as an idea within the etiology section. And in particular in patients who have used this for a long period of time, the submucous fibrosis can be a very debilitating condition. The precise mechanisms whereby it arises are still unclear, but it's pretty much the case that once you've got it, there's not really any way of getting rid of it. And the malignant transformation rate, largely from large cohort studies in India, is as presented there, perhaps about 5%. So here's a clinical picture of a patient with relatively early oral submucous fibrosis. And the point of note here is that there is this generalized whitening of the tissues around the tonsillar pillars and the soft palate. You can see that the uvula is spared. And this is due to excessive stretching because of the stiffening of the tissue. And so there is blanching associated with that. But this patient does not have too much in the way of limited interincisal opening, as you can see. However, as the disease progresses, the oral tissues become increasingly stiff. In fact, they become of what's described as board-like, and that means that there is then a marked reduction in insert incisal opening, and the patients essentially develop profound trismus. In the patient you can see in the pictures here, you see the interincisal opening is really quite small, and there are also associated changes quite widely in relation to the oral mucosa that you can see. Associated with that very often goes the pattern of staining that you see on the teeth. So what is happening biologically in these cases? Well, submucous fibrosis. There is a marked increase in the fibrotic part of the biopsy and of the tissues. So there's an increase in collagen in the underlying connective tissue, which increases the rigidity of the tissue. And then on top of that, there's epithelium which has a variety of appearances, including cytological and architectural atypia, that is epithelial dysplasia, which gives the risk of the development of oral cancer within patients who have this condition. Oral lichen planus. Now, this has been covered in more detail in some of the earlier sections on immunologically mediated disease of the oral mucosa. But there is a risk of progression to oral cancer in patients who have oral lichen planus. It varies to some extent by the clinical presentation. And so if you have a lesion which is, as you can see in the picture, in a high-risk site, that is the lateral border of the tongue, and tends to be either atrophic or erosive in its nature, that is the ones which tend to be more symptomatic to the patients, then these lesions do have an appreciable risk of progression to oral cancer. The classic reticular lichen planus, which most often presents in the buccal mucosa, that is much less so, but in no case is it a negligible risk. And there are many different examples that we could show of patients who have had long-term lichen planus and have progressed to oral cancer. This is a patient who has, you can see in the top picture here, quite extensive lichen planus extending over the labial mucosa and down to the gingiva, including the attached gingiva. And the patient was lost to follow-up rather for a number of years, and also had a significant risk factor component, and then presented 10 years later with this carcinoma, as you can see on the gingival margin.